Hello, I'm Norman Swan. Welcome to this programme on Hepatitis B, and we're coming to you on the Rural Health Channel. This programme has been broadcast from the land of the Wangal people of the Darug tribe, traditional custodians of the land and part of the wider Eora nation, and we acknowledge their elders past and present. Hepatitis B is a chronic disease, and it's grossly underdiagnosed and indeed misunderstood and undertreated. The result is preventable mother-to-child transmission, not to mention liver failure and cancer. So it's time we got better understanding this common problem, whether you're a health practitioner or just a member of the community watching us tonight, interested in your health and well-being. Now tonight, in addition to broadcasting live, we're also webcasting online. Now if you'd like to go online and try it out, then what you do is you go to www.rhef.com.au, then you click onto this program on Hepatitis B to register. Don't take all night doing it because we'll be half over before you get there, but if you're online, we certainly welcome your comments and questions. In fact, we welcome anybody watching their questions and comments. And you certainly don't have to be a professional to join in. And you can do it by phone, text, email or fax. You send your emails to questions@rhef.com.au. You can text us on 0408 408 932. Or you can phone us and we'll put you to air, 1-800-817-268. And if you've got that thing we used to call a fax, well, you can fax us on 1-800-633-410. We promise not to laugh at you, the fact that you faxed us something. If you're watching the webcast on your computer, type your questions into the live talk box and click submit. Now, we like to take questions live throughout the discussion tonight, so please send us your questions, phone us up, do what you like, but get them to us as they arise. And as I say, you don't have to be a health professional to ask a question. There's no such thing as a silly question, so just get in there and let's interact. Tonight we also are on Twitter, so tag your comments at #RHEF or direct them to @RuralHealthEd. Now, we'd quite like to know who's watching this program tonight online, so let us know who you are. And this is for people on the webcast. Are you a general practitioner, a nurse, a pharmacist, specialist? Are you in allied health? Are you an Aboriginal or Torres Strait Islander health worker or practitioner? Or are you a member of the community, just finding us and watching and pressing the live talk tab? So answer that question and we'll get the answers in a moment, and we'll ask more questions as the program goes through. Let me introduce our panel to you. Ben Cowie is an infectious disease physician with the Victorian Infectious Diseases Service at the Royal Melbourne Hospital. He's also an epidemiologist at the Victorian Infectious Disease Reference Laboratory, designated a couple of years ago as the WHO Regional Reference Laboratory for Hepatitis B. Welcome.
Thank you very much.
Chris Enright is Manager of Primary Health at the Cancer Council Victoria. Welcome, Chris.
Thank you.
Chris's work in liver cancer prevention focuses on liver cancer and chronic hepatitis B. And Dr. Annie Preston-Thomas is a public health registrar in Cairns. Welcome to Annie.
Thanks.
Annie has worked as a general practitioner in Aboriginal and Torres Strait Islander health since the mid-1990s in both Central Australia and North Queensland. She has a particular interest in chronic disease and women's health, and she was involved in 2 recent studies and reports into hepatitis B in far north Queensland. Simone Strasser, Associate Professor, is a hepatologist in the Gastroenterology and Liver Centre and the National Liver Transplant Unit at Royal Prince Alfred Hospital in Sydney. Welcome, Simone.
Thank you.
Simone has a particular clinical and research interest in hepatitis B, hepatitis C, advanced liver disease, primary liver cancer and liver transplantation. So we've got all bases covered there. Vanessa Towell is the Programme Manager for the National Policy and Education Division of ASHM, that's the Australian Society for HIV Medicine. That's a not-for-profit organisation that supports HIV, viral hepatitis and the sexual health workforces. Vanessa has been responsible for expanding ASHM's hepatitis B programme over the past 3 years. That's included the development of the National Hepatitis B Testing Policy and the establishment of Hepatitis B General Practitioner Prescriber Programme, and we'll come to that later. Welcome, Vanessa.
Thank you.
A mouthful, but worth saying. So what's the point of doing this, Simone? What's the burning deck here?
The big issue I'll illustrate with some of the people that I see come to see me as a liver specialist. And what breaks my heart is when I see a 50-year-old man who was born in Hong Kong or China or Vietnam or Tonga and who has lived in this country for 20, 25 years or longer. Maybe they knew that at some point they had a test for hepatitis B and they were a carrier. And they walk through the door because they've developed pain in their abdomen and they've been subsequently found to have a 10-15 centimetre cancer in their liver, which is a primary liver cancer. And then they have a blood test for hepatitis B, and then they're found to have primary liver cancer due to their hepatitis B, and that person is usually dead before 12 months is out because the treatment options are very limited. What should be happening is people should be diagnosed with hepatitis B so that they can access proper treatment.
And what are they often told along the way? Because is it complete news to them about hepatitis B, or are they kind of known about it?
For many people, they've actually known about it before. So they've known that they've had hepatitis B, someone did a test, told them they were a healthy carrier and it was never going to be a problem, and they've never been monitored. Other people have actually never been tested despite coming from a country with a prevalence of 10% or upwards.
So, Vanessa, one thing that we're going to talk about tonight is nobody should ever be told they're a healthy carrier. Gone, dead, buried.
That's correct. You hear too many stories of people that are told that they're a healthy carrier, and I mean, all you need to hear is healthy, really, and you think that everything's going to be okay. So they either disengage with the health system, or they are still involved with the health system, but not for their chronic hepatitis B until it's too late, as Simone said.
And what other stories should be drawn to our attention that are typical in this area, that are heartbreaking and preventable?
Yeah, look, I mean, the points that have been made already are very stark and all too common. We know that only just over half the people living in Australia with chronic hepatitis B have been diagnosed.
Only half?
Only, yeah, 56% we estimate, so nearly half.
And of that half, how many are properly treated or prevented?
Yeah, well, only 3% of people living with chronic hepatitis B are currently accessing antiviral therapy. And we estimate that at least 5 times that proportion need to be preventing the sort of outcomes that Simone's mentioned, sort of severe cirrhosis or, you know, progression to severe liver disease and cirrhosis and liver cancer. So some of the other stories are these missed opportunities, which has been alluded to with people being told they're a healthy carrier and they're disengaging and only coming back when it's far too late. Or, for instance, if someone has been diagnosed, a woman who's been diagnosed in antenatal testing for hepatitis B, and sure, we do a reasonably good job of protecting her baby from getting hepatitis B, but all too often that woman is never referred for her own health care, and sometimes those women end up with severe liver disease when their hepatitis B was diagnosed years and years before. It's a real failure.
Well, truly tragic. And the babies?
Now we've got the universal vaccination program since 2000 in Australia. The coverage of that is pretty high, but one of the failures, or one of the real areas we need to improve on, is testing of those babies born to mums who have hepatitis B, so we prove that the actual vaccination was effective, because otherwise we need to be looking after those children's health if they've acquired chronic hepatitis B as well.
Let's get to the results of our first poll. Who's watching this programme tonight via webcast? 22% general practitioners, 44% nurses, no pharmacists, we'll have to fix that up, and about 10% specialists in allied health. We don't have any Aboriginal and Torres Strait Islander health workers watching us online, but I'm sure they're watching us live via NITV, and 12% members of the community. So welcome to all those members of the community watching. And let's ask our second poll question. I'd like to know how many of your patients born overseas in hepatitis B endemic country have been screened for hepatitis B. Not 10%, 11 to 25%, 26 to 50%, or more than 50%. Now, be honest. What's the cancer story in a public health terms, Chris? So
this is a really important cancer issue for several different reasons. So globally, about 80% of liver cancer is believed to be caused by hepatitis B. In Australia, there's been recent statistics around the rates of liver cancer increasing in terms of cancer death rates. In 2007, it was 11th most common cause of cancer death, and in just 3 years that's increased to 9th. So the speed at which that rate is increasing is really alarming, and it's expected to double by 2020. So in terms of a cancer prevention strategy, the education and the awareness around Hep B is just so important.
And in Aboriginal communities?
What we did was we had a look at care delivery for patients with chronic hepatitis B, and also patient knowledge about living with chronic hepatitis B. And there were some good findings. We found that 70% of the patients were being tested with liver functions each year, but there was a lot of abnormal liver tests that weren't getting followed up. There was a lack of integration of new developments, so many patients hadn't been tested with a hepatitis B viral DNA when they should have been, and there was also a lack of specialist referral. As far as patient knowledge, 50% of patients were aware that hepatitis B meant something to do with their liver, but 88% had no idea of how it had been transmitted to them. 57% couldn't identify health protective behaviours for themselves or their family, and only 7% knew about long-term consequences such as cirrhosis or liver cancer. We also asked about alcohol, and 52% of the people said that they do drink alcohol, and the majority of those drink heavily when they do drink. And so really the implications of those findings are that chronic hepatitis B is a chronic disease, but in Indigenous communities it's often marginalised as part of sexual health, and often sexual health teams don't have the capacity to follow up the patients with chronic hepatitis B.
I've got a couple of questions. One is from Virginia Reid. Do you know what the latest statistics are in Central Australia?
I can sort of speak to that. So there's not a lot of actually up-to-date evidence on this sort of thing. There was a publication in the Medical Journal of Australia some years ago showing that mortality, of all deaths in Alice Springs Base Hospital between 2000 and 2005, 3% were attributable to end-stage liver disease in people living with hepatitis B amongst Aboriginal and Torres Strait Islander people, whereas none were amongst non-Aboriginal or non-Indigenous inpatients at the hospital. Historical seroprevalence surveys have shown prevalence estimates up to 20% amongst some remote communities in Central Australia, whereas there's been very little systematic testing going on since then. There are real approaches to try and improve this in Aboriginal medical services, but the burden is very, very significant, and liver cancer as a result is far more common in the rest of the Australian population.
Another question coming in is, there used to be a story about Aboriginal people not responding to the vaccine in the same way as the non-Indigenous community, particularly when they've completed an approach, a course I should say. Yep. What's the story?
So certainly of children vaccinated for hepatitis B in remote communities, there is evidence that there was a failure to respond to the vaccine. The causes of that are not completely known. It's likely multifactorial. One of the significant causes is hepatitis B vaccine is actually very, very heat stable. You can store it at 37 degrees and it'll still be active a week later. But if you freeze it for even a few minutes, it's gone. And so it could have been that particularly in remote communities, people were being particularly cautious about keeping it cold and might have kept it a bit too cold. And there's other factors relating to viral genotype, etc., which may be pertinent as well.
And that question came from Sarah Quehampton in the Goldfields in Western Australia, so thank you for that. Keep your questions coming in, and remember, you don't have to be an expert or a doctor or a pharmacist to call or ask a question. You can text your question to 0408 408 932. You can phone us on 1800 817 268, or you can email us at questions@rhef.com.au.
Simone, can I just add to that?
Yes.
That in the Indigenous community...
You've got another way of asking a question, or this is about the Indigenous
Just to follow on from what Ben said, the other thing is that in the early days of the vaccination program, I think sometimes in some areas there was not such a good rollout of the program, and so in some cases people had already acquired hepatitis B before they were given the vaccine, so there are definitely people who may believe that they've been vaccinated, but tests have still found that they've been positive.
I think that raises an important point of the importance of testing before you do vaccinate someone, especially if they are in a high-risk population, because the vaccination is going to have no effect if they already have chronic hepatitis B.
And those are the people that are really at risk of liver cancer because they have a false sense of security that they've been vaccinated against something that could be perpetuating, so that when they're 50, as Simone has mentioned...
So we're talking about adults here, not children.
That's adults. So really it comes back to the vast burden of the disease in Australia of people with chronic hepatitis B actually got hepatitis B around the time of birth or in early childhood. So that's when the vaccination has to be effective to have any impact at all on that burden of disease.
So give us a picture, Simone, about what is the up-to-date knowledge about how hepatitis B is transmitted, who gets what and how, and what the course is through your lifetime. So
that's going to take me a few minutes. So hepatitis B is endemic around the world, but it's
Endemic
particularly
meaning that it
it's
lives in
in the
certain countries.
population.
Yeah.
And it's particularly in the populations of countries throughout Asia, throughout Africa, throughout South America, and there are pockets elsewhere. And so any country such as Australia, where people have migrated from those countries, carry their background risk of hepatitis B. So for areas of Southeast Asia, the background rates are about 10% of the population. And that means people who come to Australia from those communities also carry a 10% risk of hepatitis B.
So they're spreading
well.
it in Australia?
No, the transmission is from mother to birth. So we can prevent that by vaccination of all babies at the time of birth, and we now have universal vaccination in Australia that prevents most of that transmission.
But if you think the mother's got it, the baby needs to get it at birth.
Well, we now vaccinate all babies at birth in Australia. So we test all mothers, but we also vaccinate every single baby that we can in Australia. So that's going to have a major impact in the prevalence of hepatitis B in the future, and many, many countries in the world are doing that. And in 40 to 50 years' time, I hope we're not doing this for them, because hepatitis B will be much less of a problem. But at the moment, it's a huge problem in the people that have come from those countries with high background rates and they've acquired infection at birth. Now, what we know about the natural history of hepatitis B is that it changes over the lifetime of a person. And so this concept
So this is where the concept of the healthy carrier
the whole
goes.
concept of the healthy carrier. So if you evaluate someone at a point in time, you might find they have very inactive disease. But if we go back to the time of when somebody
So
acquires
what's this graph we're
hepatitis B...
looking at there? This looks like something
This is a
out of,
squiggler graph.
Andy Warhol. Something.
So if we look at the first column of that graph, we can see what happens when somebody's in the first couple of decades of their life. So someone who's born, they get hepatitis B at birth, and through the first 10, 20 years of their life, they have a very high level of hepatitis B DNA. You can see at the top there. That might be 10 million,
So when you say
100
hepatitis B
million.
DNA, this is
That's
what
the
they call the
virus.
viral load. This is how much you've got in your body.
Exactly. That's the virus that's circulating in the body and is populating the liver. And that's at a very, very high level, 10 million, 100 million or even higher. But the ALT level you'll see there, which is the immune response to the virus, reflecting
So
liver
the ALT,
injury,
again,
is
for
normal.
non-medical viewers, is a chemical that goes up when you've got irritation in your liver.
Exactly. So in this phase of disease, the immune system is ignoring the hepatitis B that's there, despite it being at very high level. There's no immune response and there's no liver reaction.
So it's got a free run.
It's got a free run. If we do a biopsy of the liver, we'll see lots of hepatitis B, but no immune reaction to it, no scar tissue, no inflammation, no injury. And that can go on, no symptoms.
So this is when they used to say you were a healthy carrier,
Well,
but
this
in
is-
fact it was running riot.
This is there, it's at a very, very high level, and this is where the state that we pick up in teenagers and often in pregnant women, because they're young, and we find at that phase. But then in most people, as they get into their 20s or 30s, their immune system starts to react against the virus. And we start to see flares of ALT reflecting that liver injury that's occurring, and the DNA level will actually come down over that time. But this phase, which
So
is
if
called...
you like, the liver damage is collateral damage from the immune system
It is.
attacking the virus.
So the virus doesn't damage the liver itself, it's the immune response to the virus that's causing the liver damage. And that period of immune damage can go on for a couple of decades.
So you're now, what, 40 or 50?
So you may go through that period, you may go through it very quickly and actually clear virus and suppress it by the time you're 25, or you may keep going through these immune clearance phases over a period of 15, 20 years, and that's when liver damage happens and cirrhosis develops. So that's the key time we want to find somebody and treat them. But then most people with treatment or just spontaneous will actually go into a very quiescent phase, which we call phase 3 or immune control phase. And that's a period when the DNA level is very, very low. It may even be undetectable, even with sensitive tests.
It's hard to find the virus in your body.
Can't find the virus. And the ALT level settles back down and everything looks like it's really good, healthy, and they're the ones that were called healthy carrier. They've lost one of the markers, which is the E antigen, become E antigen negative. ALT is normal.
This is one of the blood tests.
Just one of the blood tests. And then the DNA level comes down. The GP does a test at that phase, says you're a carrier, nothing to worry about. But we know that
Not realising that you're part of this roller coaster that we see on the graph
you may
there.
have got to that period already with cirrhosis, or you may sit in that phase for 10, 15 years and then reactivate. And so we now know there's a fourth phase of infection where the virus actually mutates and becomes active again, the immune response kicks back in, and that's when more liver damage occurs. So if we want to target...
So you can't relax at any point in this cycle.
And the guidelines are that now anybody we know has hepatitis B has to be constantly monitored. Every year we can do a level of DNA, the viral load test, on Medicare, free of charge. Government pays for it to monitor where that person's DNA level is and check their liver function. And that should be done at least yearly, if not more frequently, and the people with active disease need to be referred for treatment.
So what are the tests that take us through this cycle, Ben?
So I guess there are two phases of testing. First of all, there's diagnostic testing. There's those 3 tests that we recommend anyone has if they're at risk of hepatitis B. That's the hepatitis B surface antigen, the hepatitis B core antibody, and the hepatitis B surface antibody. And by ordering those systematically on the one slip, and it's, again, fully Medicare rebatable if the clinician writes something in the clinical notes along the lines of query chronic hepatitis B or risk of chronic hepatitis B, that's Medicare rebatable. And by those 3 tests being done, it allows you to put together their complete status. Is this person chronically infected? Are they susceptible and require vaccination? Or are they indeed immune through natural infection? And once you know that and you react to it appropriately, you never need to test that person again for hepatitis B again, provided that you've reacted appropriately.
So you never have to do the diagnosis again?
Yeah, that's right, because if you've diagnosed someone, they're diagnosed, you manage them.
So what's the pattern of test results that tell you all this, Vanessa, in those 3 tests?
So there's a few things that we're looking for. We're looking for someone who's susceptible to Hep B, so that's someone who doesn't have Hep B. And with that,
so if they're all negative, you get vaccinated?
If they're all negative, you get vaccinated. And that's really important as well.
And if you've been vaccinated and you accidentally get tested, or
if you've been vaccinated, or
show?
if they're looking at your antibody levels to make sure that you've had the appropriate reaction to vaccination, you'll have positive surface antibody, and the other 2 will be negative. Whereas if you've had resolved infection, you'll have positive core antibody and positive surface antibody. And so that shows that you're also immune, but you have had infection in the past.
But you still could be in one of these phases and brewing trouble.
No, and I'll pass on to Simone for the rest of that.
So we're trying to the phases I was talking about are for people who still have hepatitis B surface antigen. They still have
So the first test is
hepatitis
still
B,
positive.
they've got chronic hepatitis B. The important thing is who should we test for this, and that's anybody who comes from a population where there's a high rate of infection. And so the new guidelines for testing recommend testing for anyone who's come from a high prevalence country. So that's anyone who's, this is people living in Australia, anyone who's come from an Asian country, for instance, African country, South American countries, even Southern Europe, there's a lot of hepatitis B. And also, very importantly, the Indigenous and Torres Strait Islander communities, where there is up to 10-15% prevalence of hepatitis B. All those people only need to be tested once to determine their status, because we're worried about infection that they acquired at birth. So once we know what their status is as an adult, or even as an adolescent or as a teenager, then we never have to test them again once we know their status.
And this has been set out really, really clearly in the National Hepatitis B Testing Policy, which was released last year. So there's often one thing that we like to focus on in our education is the need for this opportunistic testing and the fact that it is Medicare rebatable, because a lot of general practitioners, and you can understand if they're within a community that may have a big Chinese community, and so we're saying you need to test every single one of your patients.
So somebody's watching us tonight.
Yeah.
They're not Vietnamese, they're not ethnically Vietnamese or Chinese,
Sure.
or for sub-Saharan Africa. They're Anglo-Irish, but they're worried by the program. Should they get tested?
Okay.
I'll throw this one to Ben.
Okay, certainly there are other groups in the community who are identified as being priority populations, and so people at increased risk who are born, for instance, in Australia and are not Aboriginal and Torres Strait Islander people. One significant group obviously is children born to those in high prevalence populations, because again, the majority of people with chronic hepatitis B worldwide and here in Australia were infected at birth. So people born of...
Okay, so I'm sitting here worried. I'm not part of that group.
Sure.
But I work with a lot of Southeast Asians at work.
Okay. So first of all, there is absolutely no risk of hepatitis B transmission through routine social interactions, work contacts.
So how is it spread apart from mother to child?
Yeah, so apart from mother to child transmission, the second most important way of transmitting chronic hepatitis B, the reason we make this distinction...
What if I'm sleeping with one of my fellow workers and they're from Vietnam?
Sure. So sexual transmission is one of the more common, along with people or injecting drug use, one of the more common ways to acquire acute hepatitis B in Australia.
Right.
But 95% of adults who acquire hepatitis B will clear it spontaneously. They can still get quite sick through the course of acute hepatitis B, but 95% will clear it and then be in that state that
so you're not in that group.
to. But if you are infected at birth or in early childhood, then you have a 90% chance, particularly in infancy, of progressing to chronic hepatitis B.
There's an issue of stigma here, isn't there, Chris?
It's interesting that you bring up stigma. I think that there is an issue of stigma to a degree. We actually did some research recently with the Chinese community in Melbourne to investigate that and to look at how we can kind of tap into people's consciousness, really, to get them to pay attention to this. And some of the results that we had were quite surprising, that there wasn't so much an issue with stigma around Hep B. It was almost more complacency. So, as Vanessa mentioned early on, the issue of healthy carrier.
I'm okay.
Is really, yeah,
I feel fine.
I'm okay. I'll be fine. I don't have any symptoms. There was a real association with food hygiene. So there was a lot of misunderstanding about the actual.
They were mixing
causes.
it up with hepatitis A.
Yeah. Yes. Absolutely. And so the belief that there is stigma, I believe that there is stigma there, but it's also such a strong misunderstanding about what makes you at risk.
Let's get the answer to the question too, because it's relevant to this discussion. How many of your patients born overseas in a hepatitis B endemic country have been screened for Hep B? 63% of you say under 10%, so nice, thank you for being honest. 25% say up to 25%, nobody's up to 50%, and 12% of you say more than 50%. Maybe. Let's just ask another question, then we'll come to your comments. How many of your patients are currently receiving antiviral treatments for hepatitis B? If you're a health professional watching this program, up to 5 patients, 6 to 10 patients, 11 to 20, more than 21. And of course, that depends on where you practice.
There is one group, well, one instance where we do recommend that everybody be tested for hepatitis B, whatever their background, and that's before they have any chemotherapy for cancer, for instance. And that's because there are individuals in the community with hepatitis B where they are not in an identified risk factor, but it's important on an individual level, because under the force of chemotherapy for another cancer like lymphoma or breast cancer or bowel cancer, that hepatitis B can actually reactivate even though it's been there silently and can cause liver failure and death. So in fact, one situation where we do recommend that all people be tested, whatever their ethnic background, is before having any sort of chemotherapy.
And what's the risk, Ben, of co-infection with hepatitis C, given that there are some joint risk factors such as blood-borne?
Yeah, so look, that is an important issue. It's a few percentage points. It's for people living with hepatitis B, probably around about 3 to 4% are also infected with hepatitis C. That relates to the
presumably if you're going to prison with hepatitis B, you're almost certainly going to come out with hepatitis C.
Well, obviously, it depends on what particularly blood-to-blood contact is something that does occur in prison, and you're absolutely right. People who serve a custodial sentence, a substantial proportion who went in without hepatitis C come out with it. So that is true. Picking up your point before, and I don't want to let it sort of pass without responding, you asked about the person who doesn't identify themselves as having any particular risk of hepatitis B, but if they're concerned by some of the messages or some of the things we're saying, then clearly the best thing they can do is go along to their general practitioner and have a chat and talk to their general practitioner and the GP will ask things like, have you ever injected drugs? Have you had a blood transfusion overseas in the past? Have you, and there are groups in the community who are Australian-born who do have a higher risk, excluding Aboriginal and Torres Strait Islander people who are a very substantial constituent, but men who have sex with men also have a higher prevalence as well.
There's some really good community education resources available on the internet too, so if people have a general interest, there's quite a few different avenues. So Hepatitis Australia have some, there'll be resources on the ASHM website, Cancer Council have them, so there's quite an opportunity to have a look and get the information for yourself online.
Keep your questions coming in. You can text us on 0408 408 932. You can phone us on 1800 817 268. You can email us at questions@rhef.com.au, and you can tweet us, and I've forgotten what the tweet is. I think it's at RHEF Ed. I think that's what it was. I'm told that's it in my ear hole. So that's so Twitter, and we've had a couple of tweets asking questions. Just wondering what a full liver screen involves. I'm an Indigenous man who was born with Hep B. What should I do? Good question. So, got hepatitis B. Annie, what should he do? What does he go in and ask the doctor or the Aboriginal health worker to organise for him?
Okay, well, so I guess starting from the beginning, so he's somebody, he knows that he had Hep B since birth, so what he needs to do is he needs to have his liver function tested. He needs to have, so there's some things that we do at baseline. We like to know first of all, we'd like to know his E antigen status. So that would be a
What
test.
does that tell you?
So that tells you, it goes back to what Simone was talking about before. The first two columns, E antigen positive, and that generally indicates that the virus is replicating a lot. So it also means that you're more infectious to other people if you have a positive E antigen. It also helps when you put it together with the other information to have some idea of what phase he's in and therefore whether he would benefit from treatment. So then he should also have his liver function tested.
Looking for that ALT test.
Yep, looking for that ALT test. He should have a full blood count as well. And he should also be tested.
That's because if you've got liver failure, your blood count's going to start to drop.
Your platelets might go down, yeah, if you've got cirrhosis, that's right. He should also have hepatitis A and hepatitis C and HIV tested, because if...
and what about this hepatitis B DNA, the viral load, how much you've got in your body?
And that is very important, because the LFTs and the viral load will give some indication of whether he is in a phase that's not active or whether it's something that actually needs monitoring or
so Ben,
treatment.
when would he score for treatment?
Yeah, so typically in this sort of a situation, and the other thing that would probably be worthwhile doing is confirming his status, again, to make sure that in fact he does have hepatitis B, because there's a lot of people who don't understand what they've been told or different hepatitis and what's going on.
So the first time you've seen him, you might get the first test repeated.
Yeah. But so generally the people we select for treatment are those who are in the immune clearance and the immune escape phases, the second and fourth phases that Simone talked about.
So the liver is beginning to jack up.
That's right. These are people with elevated Hep B DNA and elevated ALT, so there's active liver disease occurring. The reason we intervene there is because the treatment is actually able to reduce the amount of viral replication and to return the liver function test to normal, but more importantly, we know that the treatment is very, very effective, not only at preventing further liver disease, but actually causing liver disease to improve.
So you can reverse it?
People with cirrhosis, we now know it's reversible. And when we were in medical school, we were told cirrhosis was an irreversible condition. We now know that that is absolutely not true. Furthermore, these people are at risk of developing liver cancer, particularly those with advanced liver disease. We also now have increasing evidence that for appropriate people who you start on treatment, within a space of only a few years, you can reduce the risk of that person developing liver cancer by 50 to 75%.
What are the drugs?
So we've got two classes of drugs that we use. The most common way that we treat hepatitis B and the way that's most palatable to most people is with tablets. And there are 2 tablets available well, there are actually 5 tablets available on the market, but only 2 are recommended. And that's because they're 2 drugs that are highly potent, have very few side effects, if any, are tolerated by the vast majority of people, very little toxicity, and also have very little chance of the virus getting resistant to them. So even though there are 5 different oral agents or tablets on the market, we select 2 for use in treatment, and one's called tenofovir and the other's called entecavir. And both of them are highly effective. Almost everybody will have no virus detectable in their blood after even a year of treatment, and by 5 years of treatment, 95, 90, 100% of people.
Is it treatment for life?
For the vast majority of people, it is treatment for life, and that's because this virus doesn't get cured. So some viruses, like hepatitis C, we can actually eradicate from the body after a course of treatment. Hepatitis B rarely gets eradicated, it just gets suppressed. But by suppressing it, we can affect those outcomes. We can prevent the progression to liver disease and progression to cancer.
So should our viewer, who just wrote in on Twitter, get screened for liver cancer?
So if the viewer is somebody with chronic hepatitis B, again, we can have a major impact on outcomes by screening for liver cancer. So the current recommendations are for people with chronic hepatitis B, men over the age of 40 and women over the age of 50, is when they're starting to accumulate a risk for liver cancer. And now we're recommending routine surveillance with a 6-monthly ultrasound. So an ultrasound of the liver every 6 months, and that has been shown worldwide to significantly increase the chance of finding a very small cancer, if there's going to be one there, that we can actually treat and cure. If you wait longer than the 6 months and only do it yearly or do it erratically every couple of years or occasionally or never, the chances of finding a larger cancer that we can't effectively treat is much higher. So the recommendations are every 6 months, that person with chronic hepatitis B should have an ultrasound, wherever they are. So there are now mobile ultrasounds that we can take into clinics, starting to get into some of these remote areas with ultrasounds to do that surveillance, because it's the most effective way of preventing death from liver cancer.
Other than treatment for people who are eligible.
Other than treatment. But even for people who are on treatment, we in our clinic now are still seeing people who have been on effective antiviral treatment for 5 or 6 years or longer coming up with a liver cancer, but we're finding little tiny cancers that are 1 or 2 centimetres that we can actively treat, but they're still occurring on treatment.
Sure.
But the chance of them occurring is much less.
So we're getting lots of questions in. This one comes from Joy Johnson in Victoria. What's the advice for an adult who did not seroconvert after a hepatitis B vaccination programme? By seroconvert, we mean they actually got an antibody response.
So, first of all, the most important thing for a person who's been vaccinated and hasn't mounted an antibody response is check if they've got hepatitis B. Because if you've got chronic hepatitis B and a surface antigen positive, no amount of vaccine is going to elicit a surface antibody response. So that's the first thing. Then, if this person has been documented to have received the vaccination at the appropriate schedule, you can elicit between, depending on what you do, 20 to 40% chance of getting an antibody response if you repeat that vaccination program. So another 3 shots of vaccine spaced a month apart will elicit seroconversion in a substantial proportion of people thereafter. There's incremental, it's reducing gains if you keep doing it after that point in time. And there are some people who just will not mount an antibody response. Sometimes that's people with immune suppression or other chronic medical problems. And what you do in that situation really depends on their absolute risk. Is this a healthcare worker who performs exposure-prone procedures? Is it someone who lives with someone with chronic hepatitis B? And we would tailor the advice around that.
Another question comes from Yvonne Dragic, James Cook University in Queensland. Do we know how many people have contracted Hep B from blood transfusions before donations were screened?
Good question.
Okay, it is a good question, and hi Yvonne, it's great to have your question. Yvonne's a fantastic advocate for people living with hepatitis B, who many of us know and have worked with previously. So there's very little information on that. The blood transfusions started being screened through in the early 1970s. So that's in Australia. In other countries, blood transfusions still occur without appropriate screening, and that is a substantial issue. But because the fact that we've been screening since the early 70s for blood transfusions, the number of people still living with chronic hepatitis B acquired in that fashion is actually fairly low, but I can't quantify it for a moment.
In those days it was called the Australia antigen.
Well, it was. I mean, it was among Aboriginal and Torres Strait Islander people were amongst the first groups in the world in whom hepatitis B was discovered by Barack Blumberg back in 1965. Interestingly, he was also the first person to vaccinate someone against hepatitis B by essentially purifying the serum of someone with hepatitis B and injecting the surface antigen into another person, which he called the people's vaccine, because he was taking it from someone with plenty and giving it to someone with none.
Some quick questions. I know we've got to get to case studies. Jamie Pike asks on Twitter, who should patients who are core antibody positive but surface antibody negative be vaccinated?
There's absolutely no value in vaccinating
Because they've
someone
had
like
an
that.
infection.
They've always had native infection. They'll almost all already have surface antibody, and we don't recommend vaccination.
And one of our non-health professionals watching, so thank you for the question. I'm a 51-year-old man with chronic hepatitis B, diagnosed 14 years ago. I was on lamivudine for 10 years. You're getting free medical advice here. This is what you're on about. But I was on lamivudine for 10 years, but now on Tegravir. I have mild cirrhosis detected earlier. I was interested in hearing Simone saying it's possible for my immune system to attack my liver again. Does this place me at high risk of liver cancer? Good question.
So it's a good question. So if you come off that entecavir, there's a very high chance that that virus will reactivate and become high level again and cause more liver damage. But with long-term entecavir, as long as there's no resistance developing, then it's very unlikely that any further liver damage will occur. For somebody, though, who's had lamivudine before and is now treated with entecavir, there is a risk of developing resistance, and it's very important to monitor the viral load on treatment, and that can be monitored 4 times a year on Medicare for free in somebody on treatment.
So that's your HBV
DNA. So that's
test.
really important in that setting, particularly to make sure there's no resistance emerging. But if the virus remains undetectable, that drug's working, it's going to prevent more liver damage.
So, free medical advice.
There you go, or charge.
This would cost you a fortune normally, and you got it for free by watching this broadcast. Let's go to our first case study. It's Chen. He's 28 years old. He's a student from China who presents following a recent trip back home to attend the funeral of his father, who died of a liver tumour. He's married with 3 kids, aged between 3 and 10, and he's attending your practice, Annie, as he's contracted an upper respiratory tract infection while overseas. he works in IT in an open plan office, and he's worried about his workmates, getting infected with his upper respiratory infection. Maybe he's got more to worry about.
Perhaps he has. So after addressing his upper respiratory infection, another thing that it would be worth raising with him is if he knows any more about his father's illness, and if he knew whether his father had hepatitis B or not. And you could then explain that if that was the case, that it would be well worth his having a test as well, because there's quite a high rate of hepatitis B amongst people from that area, and particularly if there's a family history. So it would be worth offering him testing for hepatitis B.
So he did, and he came back. He was, here you go, Vanessa, we'll test you out on this one. He comes back and he's hepatitis surface antigen positive. He's his hepatitis B surface antibody negative, but his core antibody is positive.
So Chen has chronic hepatitis B.
Right. What are you going to do?
Well, you're going to explain about it to him. In fact, this is assuming that you'd want to know if he's ever had it tested before, because to actually say somebody has chronic hepatitis B, you actually have to show that the surface antigen is positive 6 months apart.
I mean, that's a surveillance definition.
Yeah,
really,
okay.
It's vastly likely that this is chronic hepatitis.
Yes, it's vastly
B.
likely,
You're
exactly.
right, you're absolutely right. But
I mean, yeah. So it's highly likely.
So you want to nail this today? You don't want to nail it in 6 months' time?
I would certainly want to nail it today and say, this man's come from a high prevalence country, his father's just died of liver cancer, you've done a test, he's hepatitis B positive. I would think you can tell that man he's got chronic hepatitis B.
Yes.
Yeah. So what do you do next?
So now what you want to do is find out more about where he's at. So you want to do his E antigen. You also want to do his hepatitis B viral DNA.
See how much he's got on board.
Yes, and you would want to do his liver function test. And those three together will give you some idea about the phase of the infection that he's in.
So this liver function test, I mean, people are often told it's got to be, they think it's got to be really high. But that's not true.
No, it's not. And the definitions of what a normal ALT level, that's the one we're particularly looking at for looking at liver injury related to hepatitis viruses. The definition of a normal ALT has been revised. And on many laboratory reports, and for instance, even in my own hospital, a normal ALT is anything up to 55 in men and women. We know that's way too high. And in fact, the revised numbers are an ALT of 19 or under is normal for a woman, and 30 or under is normal for a man. And the excess, the reason why we see so many people with increased ALT in our community, and therefore the normal lab values, is because there's so many people in the community who are overweight and obese, carrying fatty liver disease, pushing up the norm in the population. But the reason that those values of 19 in a woman and 30 in a man have been set is because the all-cause mortality goes up significantly in people with an ALT level higher than those. And we see it in the hepatitis B population all the time, where someone, for instance, a man has been monitored for years, his ALT has been 45, 50, he's been told everything's fine.
But he's not.
We see them, he's not fine. We do an assessment for fibrosis, which we can talk about how we do that. But once you get that person onto treatment, within months that ALT level plummets, and then it'll be 20 the whole time on treatment, and that's that man's normal ALT level. So that tolerance of an ALT of 45 or 50 is totally unacceptable in somebody with chronic viral hepatitis, particularly hepatitis B.
I think that's just one example of why continuing education is so important. So much has changed in hepatitis B. The fact that there's effective treatments available, the fact that there is no such thing as a healthy carrier, whereas people thought that that was the case previously.
So if his ALT was up, if Chen's ALT was up and he had a high viral load, would you put him on treatment?
I would assess him further for fibrosis, and traditionally we used to do that with a liver biopsy in everyone. That terrified people. Nobody wants to go to a clinic where they're going to say you have to have a liver biopsy, particularly to access the treatment.
Particularly when you see the size of the needle.
So it wasn't that big, and we still do liver biopsies for certain indications, but up until only a couple of years ago it was mandatory to access the drugs that we need to use to treat hepatitis B to have a liver biopsy. That was a massive barrier. People would not come to a clinic.
So you've got to show physical damage to the liver before you can score the drugs.
We do, and we still need to show that there's some liver injury to access funded therapies, but we don't need a biopsy. So the new tool that we've got in our armamentarium is a non-invasive test that measures the stiffness of the liver, and it's a little bit like an ultrasound machine, except we've got versions of it that we can put into a suitcase, take on a plane and fly to clinics elsewhere. They can go into remote areas with these scans. They're called a fibrous scan, which is the brand name, or a transient elastography. And what that does is it's a 5-minute test that assesses the stiffness of the liver and tells us if that liver is pretty normal in stiffness, or if there's severe stiffness, marking the likelihood that that person's got cirrhosis already, or they're somewhere in between. And by doing that, we can take out the need for liver biopsy. We can say to that person, your liver actually looks very good despite the fact you've had infection for 35 years or 40 years, or you're 35 or 40 and you clearly have cirrhosis and clearly treatment is strongly indicated.
There's also an issue, a cultural issue around liver biopsy. So anything to do with removing a piece of the liver, it's a real barrier for some people in some of these high-risk populations.
So, can I make one point? I mean, you know, the fibroscan is a fantastic thing and it's really advanced the access to establishment of fibrosis, but it's actually, you don't have to do a biopsy or a fibroscan before you can treat somebody. So certainly on both ALT and Hep B DNA criteria, you can go ahead and treat someone with hepatitis B. You don't have to do a fibroscan, and clearly, you know, in a remote area where you don't have access to either, when we wouldn't suggest that you should wait around till you can do that.
And you've got to be a trained GP prescriber if you want to be a general practitioner and prescribe these drugs. Is that right, Vanessa?
So GP prescribing is something that's still fairly new. Only in the last few years has that been a program that's available. So prior to that, it was gastroenterologists or infectious disease physicians or other hospital specialists who were able to prescribe these drugs because they are an S100 drug, which is a specific criteria of drug. However, now there are GP prescriber programs that people are able to access, so these drugs can be prescribed for maintenance therapy within the community.
Let's go to the results of our third question. How many of your patients are currently receiving antiviral treatments? This is for our health practitioners watching. 86% of you said not 5, 14% 6 to 10, and that was basically it. And again, it's hard to tell from that because people could be in low prevalence areas. Although
it would fit with what we know, like 3% of people in Australia with Hep B are on treatment.
Let me ask another question of you. Have you, again for our health practitioner audience, have you vaccinated any adults against hepatitis B in the last 12 months? If so, how many? So no, yes, fewer than 10, yes, between 11 and 20, yes, more than 21. Let's have a sense of that. So what sort of education programs are out there, Chris?
There's a lot of education available, both for the primary health sector and for just the general community. I think the primary health sector is really important in this because it is diagnosis of hepatitis B can start with a simple blood test that's Medicare abatable. So there's been quite a lot of focus from various different organisations. Cancer Council, I know Ashton does a lot of work in not only the S100 prescriber courses that Vanessa was talking about, but just general upskilling around the issues around hepatitis B and the potential for liver cancer, so hepatitis B as a cancer prevention strategy.
And there is actually a brand new online module for people who are watching from rural and remote areas on hepatitis B that looks at testing for hepatitis B, monitoring for hepatitis B, how you can assess those phases of disease that Simone has spoken about, and also exploring the link between hepatitis B and liver cancer.
And there's a really terrific website, Hep B Help, as well, which is essentially Hep B 101 for a GP who might not necessarily see a lot of patients, but needs accurate information for the patients that do come in. General public can have a look. There is a resources for patients.
Can I comment on that? There's also a lot of push from the communities that are affected with hepatitis B to increase awareness within those communities. And so it's going to be increasingly more common for a member of the public from that community to walk into their general practitioner and say, I've heard that I should be having a hepatitis B test, can you please do it? And it's really important that that GP knows what to do in that situation, that they actually do the appropriate testing and diagnose whether that person needs vaccination, for instance, or has chronic hepatitis B and needs to be further assessed, and to also use that as a way into their family so that all people who are at risk know their status.
And to continually dispel that healthy carrier myth, that's where that can be done as well in primary care.
Thanks. And here's another example of an education program for the public. Nikki Newley-Guara from Hepatitis Queensland.
I'm a descendant of the Wutiti people in Shelburne Bay and also Darnley Island in the Torres Strait. I went to university and studied art, fine arts, and that's where everything started happening. The project that we're working on right now is going up into the Torres Strait. I'm up in Thursday Island for 3 days and to cover the whole community about viral hepatitis B.
So we'll go through what it is. What is hepatitis?
The key point I want to get across to community is the importance of treatment and management of Hep B while living with Hep B. I thought, why not use art as a medium to educate people? And that's where it all started. So now I think that we've worked in about 60 to 70 Aboriginal communities. I've got a strong passion towards making sure that people know about viral hepatitis. I mean, once you've lived with viral hepatitis, you do know the importance of knowledge around it. At the beginning, I noticed no one really knew what Hep B was. By the end of the workshop, they do. So I'm happy with that outcome.
I showed a straight flag.
A great educational program there in far north Queensland. Let's get the answers to your last question. Have you vaccinated any adults against hepatitis B in the last 12 months? If so, how many? 1 in 10 of you said no, you haven't. 50%, but fewer than 10. 20% between 11 and 20, and 20% yes, more than 21. Well done. Our next case study is Madeline, a 24-year-old woman attending your practice, Annie, you're busy tonight, for shared care of her first pregnancy. Madeline was born in Australia to Vietnamese parents. Her antenatal serology screen, that's the screening for our hepatitis B, shows that she's hepatitis B surface antigen positive. Her initial assessment also shows her to be hepatitis B antigen positive, E antigen negative, and her viral load was more than 17 million.
You'd be interested to know whether she has had any testing before, to know whether this has been known about before. You may consider doing an IgM, which would give you an indication if it were acute infection. But the main thing with her is that a pregnant woman with a high viral load and E antigen positive has got a reasonably high chance of that being transmitted to the baby at birth. And so the baby will be given immunoglobulin and vaccination at birth, but this woman should be referred and discussed with a specialist because she may be a candidate for antiviral therapy.
Which specialist do you fancy referring her to?
Good one. Good one.
So the issue here is that we've been vaccinated. We know we've been screening for hepatitis B in pregnant women. We've been finding cases and we've been vaccinating the babies and giving them immunoglobulin or direct antibody at birth. But there's a failure in these particular women with very high viral load of about 8.5 to 10%. So even though those babies have had immunoglobulin and been vaccinated, still many of them will still get hepatitis B. And so there's now increasingly recommendations around the world to assess that woman and to actually give antiviral drugs in the last 2 to 3 months of pregnancy.
So just like HIV?
Yep, to prevent that transmission, not throughout the whole pregnancy like with HIV, but in the last trimester of pregnancy. If we bring that viral load down, it doesn't have to be undetectable, but just bring it down by 100-fold or 1,000-fold, we can reduce that transmission close to zero. And so now recommendations for these high viral load mothers are really to be assessed and have these options discussed with them. We're not going to force them to do anything. And of course people have concerns about taking things in pregnancy, but this is late pregnancy when the baby's fully formed. And if we can do something to reduce that transmission and that failure of our normal strategy, then it's really, really important.
That mum also needs to be followed up and her healthcare needs to be looked after in the long term, and the rest of her family need to be screened for hepatitis B as well.
The ball is often dropped.
Yeah, we know that in more than 90% of cases in recent studies, the woman herself was not referred for specialist care despite it being present in the hospital where she was being tested and managed.
This is the extraordinary thing. People know, but they don't do anything about it.
Yeah, there's a real failure in that, making the link.
And this is a place in Australia where we've got universal testing for hepatitis B in every single pregnant woman, and yet we're not following up on those findings. We're not looking after the child, we're not looking after the mother, we're not looking after the rest of the family.
So the baby gets immunised at birth and immunoglobulin?
That's correct.
And is it hepatitis B immunoglobulin, a specific immunoglobulin?
Yeah, it is. It's specific immunoglobulin that's been derived from plasma donors who have high surface antibody titers, and it's made from their serum.
And then they go on and have the full course of vaccination because that's part of normal newborn vaccination program. So they get one within 12 hours of birth, and then there are other 3 routine vaccinations.
And then it should be tested.
Ada Partridge from Western Australia, a paediatrician, asks, any chance you may touch on hepatitis in children, particularly the adolescent?
Yep. Okay, so look, certainly hepatitis is usually, so hepatitis B, as Simone's gone through the natural phases, for a child born and infected at birth or in early childhood, most of those children will be in that immune tolerance phase, so have very, very little or no liver disease, but that's not all of them, so they do need active monitoring and management. In adolescence, depending on the genotype and the country that the child's from, they can enter that immune clearance phase and things can become more active. There are treatments available, so they should be referred to a paediatrician or a service with experience in managing hepatitis in children, and there are several of those now in Australia. And then that period of transition between adolescence into adulthood, they really need to be engaged with ongoing monitoring with adult physicians, because that is exactly the time when many go through and start getting active liver disease.
Have you ever seen liver cancer in an adolescent?
Yeah, well look, me personally, no. Do we know what happens? We absolutely do. 4% of children in a large Italian study from the 80s under the age of 10 had cirrhosis. And also we saw liver cancer incidence drop markedly in Taiwan amongst paediatric populations once the infant vaccination program came in. So can Hep B cause liver cancer in children? It absolutely can.
It also can cause it in young adults, and particularly the population that we're concerned about is our African migrants, where we're seeing large cancers present in their 20s or even late teens, which are untreatable and cause death in a short period of time. And a 21-year-old beautiful man from Sierra Leone or from Somalia never knew they had hepatitis B again, present with pain, huge cancer, and we're seeing that. And
just finally, the mix with obesity and alcohol, we know that if you're obese and you drink alcohol, you increase your risk of cirrhosis by about 17-fold. How does obesity, alcohol and hepatitis B, how do they interact with each other?
Any cause of liver disease will interact with any other cause of liver disease. So that if you have 3 simultaneous causes of liver disease, you're much more likely to get damage, although those factors probably don't affect the replication of the virus. So with hepatitis B, we've got a good tool to find out how much virus is present in the blood. We've got tools to find out how much scar tissue is present, but in that situation you raise, we can't really tell which of the factor is causing the scar tissue because all 3 can. So in that situation it's important to treat the hepatitis B and to treat the other causes, get the weight down, increase the physical activity, get the alcohol consumption down, and to try and prevent liver disease from all those causes. And they're all independently attackable.
And another question came in just very briefly. Do migrants get hepatitis B immunisation or testing at source country?
Not routinely. Certain categories of migrants, so healthcare workers or pregnant women who are migrating or children being adopted from overseas do get screened. We recommend that someone who has migrated to Australia should be tested for hepatitis B for their own health protection, and this is a really cost-effective way of preventing end-stage liver disease, liver transplants and liver cancer.
Well, we're near the end of the programme. What are your take-home messages for those watching, including the general public? Vanessa?
So I guess my message for primary care professionals would be opportunistically test those at risk for hepatitis B. If you have people within your practice from high prevalence countries, all of them need to be tested, and all you need to do is test once to establish whether they're susceptible, immune, or whether they have chronic hepatitis B and need further management. And for the people from those high-risk populations, if your doctor isn't offering it to you, ask for it.
And now you
it's
know
good
what to ask
find
for.
out. Absolutely.
Also to take the opportunity to monitor people that you have identified with hepatitis B, and that we can prevent progression to severe complications, and we can identify early cancers by appropriate monitoring and surveillance in those people.
So again, if you're in that category yourself as a person, demand the monitoring, demand the screening.
And you're not going to be if you're the GP, you're not going to be over-servicing by doing those things. They're in international guidelines.
Annie?
I think just to reinforce Simone's point, chronic hepatitis B is a chronic disease and it needs to be managed as such.
Chris?
I would say as a cancer prevention strategy, the general community need to get tested and either get vaccinated or get treated, and to just act on it. Act on it.
Just do it.
Inform yourself and just do it, yeah.
Ben?
And I'll reinforce all those points. We know there's 220,000 people living with Hep B in Australia, only just over half of whom have been diagnosed. And you can capture the risk of Hep B infection with 2 questions. Where were you born and are you Aboriginal and Torres Strait Islander? That's 2/3 of those 220,000 people can be captured in that way. We just have to do this.
Get it done. So you heard. And I hope you're going to get on your bike and do it, whether you're watching as a member of the public or a health practitioner. And I hope you found this programme on hepatitis B interesting. I certainly have. And if you want to find more about the issues raised in the programme, or you'd like to watch this programme again, you can go to the rhef.com.au website, the Rural Health Education Foundation website, and click on the Hepatitis B programme. If you're a health professional, don't forget to complete your continuing professional development evaluation form, which can be completed online. Unfortunately, we don't have one of those for consumers, but you just have to go with the flow. You'll receive a certificate of attendance and, if eligible, CPD points. Our thanks to the Department of Health and Ageing in Canberra for making this programme possible, but really thanks to you for taking the time to watch and contribute to our discussion tonight. We'd appreciate your feedback on the programme. Your comments, whether positive or negative, are very important to us. Let us know you watched the programme by sending us an email or a text or tweet, and feel free to share your views. We'd love to hear them. I'm Norman Swan. Goodbye, and I hope you join us again soon on the Rural Health Channel.